Hello, I'm Dr. Lewis Hassel, and welcome to our program called Digital Surgical Pathology, a joint venture with Path Presenter and the Digital Anatomic Pathology Academy, part of the Digital Pathology Association's services. Our program today comes from the realm of GI pathology, and it's quite an unusual case of a patient who presented with masses involving both the liver and the pancreas. So the patient is 70 years old and presented with some weight loss, some difficulty with indigestion and so forth, and on further evaluation was found to be wasting due to some difficulties with obviously her pancreas. In this sort of a situation, one can wonder, of course, presumptively, the liver is a very common site of metastasis. And so one might think that the pancreas might be the primary site. However, if we look more closely, actually, we see that there are a number of tumors which can and often do present with metastases to the pancreas, either at initial presentation or at a subsequent period of their evolution. So kidney tumors, lung tumors, colorectal tumors, breast, liver, and ovary also can present with masses in the pancreas, and particularly if the primary tumor has already been treated, can occasionally be a source of confusion, either as a metastasis or a second primary. Of course, in the liver, a very similar list, a slightly different array of tumors can present in the pancreas. So in this situation in our hospital, the interventional GI pathologists or GI gastroenterologists took to their endoscopes and were able to localize using ultrasound these lesions both in the liver and in the pancreas and obtain suitable needle biopsy samples. So here we see one of these. The first that I examined was from the liver. And as you can see, here's a little bit of liver, normal liver tissue. And then we have this neoplasm, which has a kind of a solid trabecular pattern with some areas of sort of glandular spaces, a little bit of mucin here. And maybe in some of the cytoplasm, you can see that. And pretty high grade sort of tumor. Looking a little bit further, however, in this lesion, we also note that there's some kind of spindly stroma associated with it in areas, and some of these stromal cells are a little bit bizarre, high-grade looking kind of cells, a couple of binucleate cells in areas. So it's a little bit of a different presentation or different appearance, although it looks like it's probably underlying an adeno type of carcinoma, an adenocarcinoma, given that we're making some glands, we have some mucin and so forth. So then going forward and looking at the liver, or excuse me, looking at the pancreas biopsies, we saw a somewhat different picture in this site. So here we see a very, very high-grade tumor with, some background pancreas tissue, but a very cellular stroma. So this is not the usual picture of ductal carcinomas of the pancreas, which tend to be rather paucicellular, have a lot of desmoplastic stroma, but don't have this very cellular appearance. And as we look at some of these areas, these cells, you'll see here that these have some bizarre pleomorphic nuclei, some horseshoe shapes, occasional binucleate shapes. And many of them have this sort of eccentric location of the nucleus with a very eosinophilic either inclusion or a component to the cytoplasm. Some would say this is sort of a rhabdoid type of cell. Again, pleomorphism, giant cells associated with this, but they're not the osteoclast type of giant cells that we would associate with a typical giant cell carcinoma. These are tumor giant cells with a pleomorphic appearance. So in this situation, I wondered, first of all, is this one tumor or two tumors? Are we looking at something where we've got a dedifferentiation component? And with careful search, there were a few areas such as this gland here, which I think looks to me to be probably a malignant gland. The nuclear features are very similar to the surrounding cells. So we have sort of a sarcomatoid differentiation or a very high-grade appearance, but a component of adenocarcinoma here. So in many organs, this might be classified as a carcinosarcoma. Rather in the pancreas, it usually is the pattern we associate with undifferentiated carcinoma, which can have a variety of types. So we did some immunohistochemical stains, and this is an example of one of those performed on the pancreas. Several of these were also done on the liver to verify that the immunoprofiles in both tumors were quite similar. But here we can see the CK7. As you can see, it's nicely decorating the glandular structures. But notice here also that these spindle-shaped and stromal cells, as well as these bizarre cells, are also lighting up nicely with this marker. Now, because of the rhabdoid component, we wondered whether there might be an element of myogenic differentiation. We did a Desmond stain as well. And as you can see here, well, maybe you cannot see very well here. As you can see here, this is totally negative in these cells. And similarly, the myogenin stain was also negative. In contrast, we look at the vimentin stain. Here we see again that these cells are nicely positive and therefore co-expressing vimentin and cytokeratin, both in the glandular component to a degree, but certainly within the stromal component that you can identify here. So based on this immunophenotype and morphology, we felt like this best fit into the category of undifferentiated pancreatic carcinoma with rhabdoid features. So this is a relatively uncommon variant of pancreatic carcinoma that usually presents as a bulky mass in an older patient. And as we see in our case, they co-express vimentin and cytokeratin. Other features that have been reported have been loss of E-cadherin. And most of these cases are quite cellular, as we saw in our case. Myeloid markers, although certainly suspicious for myeloid type of morphology, are uniformly negative. Now, one very interesting study looked at the role of SMARCB1 and KRAS mutations in these undifferentiated carcinomas. And found usually retention of SMARCB1 or INI1, which was true in our case, and mutations in KRAS. These markers may be of significance because at some point down the line, they may be targets for therapy. Unfortunately, this is a tumor, at least currently, that has a very poor prognosis with, as illustrated in our case, early metastasis. And we differentiate this from so-called giant cell carcinoma, another variant of undifferentiated carcinoma, because it lacks the true osteoclast-like cells. and only rare glandular formation is identified. Although it's interesting in our case that the metastatic lesion had such quite clear-cut glandular formation, and one might wonder whether that was an metastasis from an earlier clone of the lesion, or whether in the metastatic site it had preference for those type of cells to be identified. So in summary then, our final diagnosis was undifferentiated pancreatic carcinoma with rhabdoid and giant cell features, in this case with retention of INI1, and most likely by virtue of the association with similarly reported cells, probably KRAS mutation related sort of lesion. Of course, many pancreatic carcinomas have a variety of mutations, and these will tend to accumulate as you get more further along the neoplastic degeneration line. So thank you very much for joining me. I hope that you enjoyed this, brought a little spice to your day. If you like this, please don't hesitate to hit the like button and share your comments. We also certainly welcome your subscription to our channel so that you'll catch future releases as we progress and find additional materials to share with you. So until next time, thanks so much for joining me.